Thank you. Good evening, all. I'm Reshma. And in the previous class, you all learned more about palliative care. And now I want to hear from you what you mean by palliative care. Any of you, please? What do you mean by palliative care? You can unmute from your end and speak, or give your comments in chat if that is more comfortable to you.
Ma'am, palliative care, I think it's an entire comprehensive care approach taking into aspect all considerations like psychosocial, emotional, psychological, financial, and it looks into pain management as well, other than just treating the disease. It's more of compassionate care and giving a person a life with dignity and giving a person more empathetic and a sympathetic approach than just, like prescribing medications and saying that this is what has to be done. It also takes into consideration the entire family aspect and counsels the family as well. So it's an all-in-all care for the family and the patient and the near and dear ones.
Thank you, Melanie, for that. Anyone wish to add to what Melanie has said? So we have a chat like palliative care helping people live well. Very good. So basically, it is enhancing the quality of life of a patient and family members. Okay, today we are discussing about the home-based care and who needs home care and what is the need for home care and what are the main components, and for a effective home care, what are the things needed, like that today we are discussing. From that word, what you understood from home-based care? Any of you, please?
Ma'am, home-based care is the kind of a care that's required by patients who would want a home setup, and those are the very last stages of their lives, and they would want to live their last stages in the house itself. It's like having a hospital set up within the house with the family and having a person there to take care of the needy.
Okay. Thank you. Next. Need for home care or who needs home care? What is the need for home care? First point is physically unfit or unable to travel. What do you mean by physically unfit? Physically unfit means? What do you mean by physically unfit?
Someone in a position who's not able to move or cannot be transported from one place to another.
Any other answers?
A person who cannot take care of himself or herself.
Okay. Unable to do their basics. Okay, physically unfit. This is one of our patient. The patient is having severe pain. In this picture, we know the patient is not only affecting with the pain, the family members also. We know in palliative care, mainly we are focusing on the symptom management. And for this patient, due to the severe pain, we can't able to transport this patient to a hospital. In this situation, we can arrange one home visit or home-based care for this patient for symptom management. And after controlling the symptoms, we can ship this patient to a hospital. Physically, if there is any pain, vomiting, or any uncontrolled symptoms, if the patient is experiencing, we can arrange one home-based care for that patient. And this is the next picture. This is one of our patient. She is staying alone in a house. And there is no one to bring this lady to the hospital if there is any symptoms develop. And this case also we can arrange one home visit for that patient. And next is about the financial strain. We know nowadays the healthcare expenses are more. We all know for a daily wage man, he is only getting 600 to 1,000 per day. But for a single USG abdomen, we are spending around 800 to 1,000 rupees. Like that, day by day, healthcare expenses are increasing. So most of the patients affected with severe illnesses, they are going through severe financial strain. Next. Then this is one of our patient house, and This patient is quadriplegic and there is no good road conditions to reach that patient house. And that quadriplegic patient is also having continuous bladder drainage. We know if a patient is with continuous bladder drainage, there is a need to change the catheter in 3 to 4 weeks. Is it possible to shift that patient every 3 to weeks a hospital? Is it possible? No, it is difficult. So we can arrange one home visit for that patient. That we mean by for road conditions. Then walking distance to get to transport may need to carry. These are some of the points for arranging one home visit for that patient. Next. Then components of home-based care. We know in palliative care, we are treating the patient as a whole. Like that, the main components are physical care, emotional care, social care, and spiritual care. First, we are discussing about the spiritual care. In spiritual care, what we are focusing is, in spiritual care, we are focusing on the physical symptoms. Example, pain, vomiting, delirium, nausea, like that. We are focusing on the physical symptoms. And we should assess the symptom first, and we are treating that symptoms. In that picture, the patient is having severe pain. Here we are not treating the disease. Here we are treating that symptom, that is pain. Then about the provision of physical aids. We know most of the quadriplegic and paraplegic patients are always spending their remaining lifespan on their own bed. Just imagine if we are providing one wheelchair for that patient, and we are providing good training for bed to wheelchair shifting. What is the impact of that training? Is there any impact on their life? If we train that patient to shift from wheelchair to bed, and also we are providing one wheelchair, what will be the impact?
Their life
The person
quality
will
will
be
improve.
more confident.
Yeah, there we are providing hope and confidence for that patient, also the family. After getting trained from bed to wheelchair, they can move at least around their house. They can go to outside of the house with. They can communicate with their friends like that. Here we are improving the quality of the life of that patient as well as the family. Next is about the follow-up. When we are providing palliative care, we should think empathetically. And when we are thinking like empathetically, in that bed, we can't able to see that patient. Now we are on that bed, or any loved one is sitting in front of us. Like that, we are thinking empathetically, and follow-ups are essential. And if we started pain medications for that patient in the first visit, and after that, we should take a regular follow-ups for that patient. If we started pain medication in the first visit, here what we are doing is we will arrange one phone call follow for that patient on the third day. If the symptoms are controlled, we will arrange regular home visits, and if there is no symptom control, we will arrange admission for that patient. Like that, in physical care, follow-ups are very important. Here we are treating the symptoms of the patient. Next. Next is about the emotional care. We know in emotional care, just imagine if you are experiencing severe abdominal pain, what will be the first thought? What will be the first thought if you are experiencing severe abdominal pain? To get rid of the pain. Yes, Vidya. Any more answers? So you are having a
fearless among the patient's mind that what will happen.
Okay, what will happen to the pain? Will the pain get reduced or increased or something? So that concern will always be there.
also we will have a feeling of fear, like maybe I have any severe disease or something.
Yeah. Yes, the fear of a more severe pain coming in front of severe disease diagnosed and all. Yes, correct.
Right.
Thank you. Mostly we will think about, is this cancer? We will not think about ulcer, gastritis and all. The first thought will be cancer. And in our palliative patients, here the breadwinner of the family is affected with severe illness or diagnosed with cancer. And for a small abdominal pain, we have repeated sleepless nights, loss of appetite, fear and anxiety. But here a person is diagnosed with cancer. How the emotions will be affected? They will feel fear and they are more anxious about the prognosis. Sometimes they may feel suicidal thoughts, depression, they feel guilt, loneliness, feeling of being a burden, loss of meaning in life. So when we are treating the patients in palliative care, we should address their emotional thoughts also. Most of the patients are going through these stages. They are more anxious about the prognosis. So we should give special attention to the emotional care. Next is about the social care. In social care, what we are doing is, just imagine the breadwinner of the family is diagnosed with cancer. After that, he can't able to go for a job. There is no job, means there is no money, and even they have no food to eat. Then we know nowadays healthcare expenses are more, and for that they will spend their all savings. Then they will lose their home, land, etc. If there is no money and due to the repeated admissions and follow-ups, they can't educate their children properly due to financial constraints, and they can't unable to get the children married off, and even though they will not get a status in the society, and they will feel stigma. And from this point, we are thinking about the vocational rehabilitation. And in this picture, this is one of our patients. He was the breadwinner of that family. After getting paraplegic, we put a petty shop for this patient. Now he is the breadwinner of the family, and he is supporting his family. Like that, from this point, we can think about the vocational rehabilitation. If the patient if we can't able to involve the patient to the vocational rehabilitation, next we can consider the primary caregiver. If the wife is interested in doing any activities like sewing, or if the patient or daughter is interested in umbrella making, like that we can rehabilitate the patient and the family. Next is about the spiritual care. What do you mean by spiritual care? What do you think about it? Spiritual care.
God that God is mighty and He will save from the danger from the disease.
Elena, it wasn't clear. Can you repeat it once again? Spiritual can be connected with religious belief, yes. Elena, can you repeat it once again?
Seeing God that God is almighty and save from the disease.
Okay, like considering God as the Almighty and the source of every sufferings we have, kind of religious beliefs, yes, that can be part of a spiritual. A relation with any higher power, yes. Okay, spirit. People blame
Have I
them.
gone wrong somewhere?
Yes, where have I gone wrong? Correct. A thought like that. People blame themselves that something bad they did. That is why they're getting that same. Yes. So these are some examples of spirituality. Yes. And we know that spiritual care is not only focusing on the religious beliefs or the caste. It may be the patient relation with the surroundings, sometimes relationship with some persons, some relationship like that. It is not only focusing on the religion or the caste or religious beliefs of that patient. And this is one of our patient. The patient and the daughter is staying along in the house. When we are visiting this patient house, they are repeatedly asking these type of questions like, God, why did I get this? And my mother is a very nice person. She takes good care of us. Why did this happen to her? I don't have anyone else. If you are in that home care team, what will you do? If they are asking like that, what will you do? How will you manage this situation? How will you manage?
Listen and try to understand why the person is feeling what the person is feeling.
Yes. Any other answers?
Maybe also give a perspective to the primary caregiver, the child of the mother, saying that she's suffering and we need to be there for her, console them, and try to say that it is bad, we understand it, we are trying to make it better, and otherwise we need to be there for your mom and need to take care of her just the way she took care of you. Now it's your turn to return whatever she's done for you.
Okay, yes, true.
Don't get into any kind of blame game. Whatever is in front of you, you have to tackle it in a good way and help the patient instead of getting into a blame game.
Yes, yes. Okay. Okay, when they are asking like this, listen the family and patient and family actively and slowly explore the reason for these type of questions. Like that, we are managing these type of questions while we are doing home care. Active listening is the best method for caring, spiritual care. Slowly, we can explore the reason for these questions. The next one.
Can you explain more, ma'am? Like how will you answer to the first question? What if you are in that position? How will you answer?
Yeah. In the first, when we are conducting first visit to their house, most of the patients are asking like that. And through repeated home visits only, we can make a bond with the patient and family. Slowly, we can explore the reason for that. And we are what we are doing is we will communicate the patient and the family. We are arranging separate sessions for that, and we are exploring the cause for this type of thoughts. Like we are managing these type of patients. We will arrange separate sessions for the patient and also the caregiver. So basically, there may be one concern with the patient is suffering, which makes that person think like that. So our main motive is to understand from the patient's itself why is he or she thinking like that. So it can be done through active listening, having questions around the same questions and all, getting different replies from the patient, and also immediate caregivers. That is what Sister Reshma said, by immediate people around, immediate caregivers around. We will have separate session for each person, have a elaborate questioning around with them, in like keeping in mind that it is everything favoring the patient. We are trying to have a better care for the patient. So likewise, we can have different questions regarding the same question which the patient asked, like why did the God doing this? And like getting answers, and if possible, trying to give some help to that patient. If not giving any false promises. I hope it was answered. Jarapal Srinivasan. Yes, thank you.
Yeah, ma'am. Yeah.
Thank you. For organizing a home care services, we need some important factors. First one is home care conveyances. We need a vehicle for reaching the patient house. Next is we need home care kits. We know if a patient is admitted in a hospital, we have all the utilities around us. But here we are treating the patients in their own settings. We are going to their homes. So we should take all the medicines and procedure articles. We should take. Next. And this is our home care kit. One is for medicine bag. In medicine bag, we are arranging medicines like in one box, we are arranging pain medicines. And in another box, medicines for gastrointestinal system, then neuro medicines. Like that, we are arranging medicines. This is in the medicine box. And in one bag, we are keeping the records, then BP apparatus, like that, articles, whatever we needed for examine the patient. And next also, we are having a syrup bag with us. In syrup bag, we are keeping all the types of syrup while we are going to home visit. And one bag is file bag. In file bag, when we are conducting home visits, we will take the file bags, the patient files and records in that bag. Like that, we are conducting home visits. While going to home visit, we should take all the medicines and procedure things. If the patient is on continuous bladder drainage, we should take Foley's catheters with us and all the articles needed for that procedure. And we are also carrying wound dressing sets with us. Like that, whatever we needed, we will take. Then trained volunteers. We know volunteers are the vital parts of palliative care. Volunteers from their own community, and it is very easy to volunteers are helping us to identify patients from their own community. And we need trained volunteers for organizing a good home care services. And also we need trained healthcare professionals. We need trained healthcare professionals in palliative care. Then repeated team meetings and discussions are essential for organizing a good home care services. What we are doing in pallium is after conducting home care, we are arranging repeated team meetings and discussions regarding the patient story and taking suggestions from each of the team member. And through these team meetings and discussions, we can improve the quality of the life of the patient. And we should need a regular follow-up also. I already said if we started a pain medicine for that patient, or we teach the patient how to take care of her wound, but we are not taking regular home visit, regular follow-ups for that patient, there is no use of the first intervention. So we should follow regular follow-ups for our home care patients. It is very important in home care services. Then types of home care. There are mainly 4 types of home care we are conducting. First one is doctor-led home care. Next one is nurse-led home care. Then social worker-led home care and volunteer-led home care. While the caregiver or the patient is came for registration, now at that time we will get a clear idea about the patient condition, diagnosis and all. And according to that, we are choosing the type of home visit that patient needed. If the patient need one doctor visit, we will arrange one doctor-led home visit for that patient. And if the patient is needed nursing care first, then we can arrange one nurse-led home visit for that patient. And if the patient and family is experiencing or going through any severe psychological issues, we can arrange social worker-led home visit. And we are also conducting volunteer-led home visits. In pallium, mainly we are conducting nurse-led home visits, and in our home visit team, we have one doctor, one nurse, one social worker, and one volunteer and palliative care executives. These are the 5 members in our home visit team. Mostly we are conducting nurse-led home visits. And if at the time of nurse-led home visit, if the patient need any doctor's advice, what we are doing is we are arranging one telehealth services or any WhatsApp call with the doctors. Like that, we are arranging and caring patients in pallium. Then next is about the emotional support. We already said in palliative care, emotional care is very important. Most of them are going through fear, anxiety, suicidal thought, depression, guilt, loneliness, and all. So emotional care is support is very, very important for the patient as well as the family. Through communication only, we can provide emotional support to the patient and the family. So for providing good emotional support, we should communicate with the patient and the family. And we are conducting separate sessions with the patient and family to explore the problems. Only after exploring the problems, we can give effective emotional support for the patient and family. So that's why through good communication only we can give emotional support. Next is about the general hygiene or bed for a bedridden patient. We know if a bedridden patient is admitted in a hospital settings, we know there are so many persons to taking care of that person. Doctors, nurses, like that, so many of them. But when we are discharging these patients to home settings, who will take care of them? Who will take care of them at home? In hospital, the nurses are taking care of them.
Family member.
Yes, family members. Family members means the caregivers. Family members. There is only one primary caregiver is there. If the husband is the patient, most of the time the primary caregiver is his wife. Like that, when we are discharging these patients to home settings, we should ensure that client is getting daily bath or sponge and he is getting proper skin care and getting oral hygiene. We know 90% of the systemic diseases are causing through poor oral hygiene. So we should ensure the patient is getting daily bath, proper skin care and oral hygiene. Okay, we know the most common in most of the bedbound patients, they are more prone to develop pressure sores. And prevention is, we know prevention is better than cure. How we can prevent bed sore? How we can prevent? Any suggestions on that? How to prevent a bed sore?
Metrogel and petroleum jelly mix.
By taking skin care, by sponging.
Yes. So
changing of positions
changing of
while
position.
sleeping.
Perfect. Yes, we heard about the medication part and also
Continuous change of position while sleeping.
Correct. Yes.
Regular change of bed sheets and bed linen.
Correct. Change of bed linen and all. Yes.
Water bed. Suggesting to take the water bed.
Yes, the usage of water bed or air beds, whichever
Air bed. Yeah.
Yes.
It will help.
Yes.
Try to keep the wound dry. Move the patient, turn the patient on side and expose the wound a little to the air so it dries up. It doesn't remain wet.
Yes. Thank you all. Okay. For bed sore prevention, we should ensure the client is getting maintaining general hygiene at the home care settings, and he is getting proper skin care, then comfort devices and follow-up care. In general hygiene, we should make sure the client is getting at least a daily bath, then skin care. We should, before discharging the patient, we should teach them how to give back care and skin care, then comfort devices. Next. These are the comfort devices. We know airbed and water bed. And if most of in our area, most of our patients are in rural areas, and most of if there is no electricity, we can prefer water bed for that patient. Like that, according to the situation of the patient and family, we can select airbed or water bed. Then I already said follow-up care is important. We should instruct them about the position changing, and we should instruct them position changing and all. So follow-up care is very important. If there is bed sore, we should teach them how to take care of that wound also. Next, we are going to one video. That was a video on how better we can make a bed. So being a volunteer,
Madam,
once
I
you,
have one question. The patient was not using any air bed or any water bed. It was a hard bed. Why, ma'am, in the video?
no, this is just an video which we show our caregivers or like teach them how to make the bed making. So the mattress is not a matter of concern here. This is how we can change the linen of the bed. That is what we were trying to show. And
Okay.
one of the important cause of bed sore is friction. While we are changing the bed sheets, the friction is the main cause for bed sore development. So we are teaching like this how to change the bed sheets. That's why we can decrease the friction and risk for bed sore. Is it clear? So we demonstrated with this a normal bed, normal linen and all. With this same can be done with an air bed or a water bed too. This is how we teach the caregivers how to do bed making at their home. So being a volunteer, you can also support them doing it. And also you can help them or instruct them in how better you can do it without causing any friction or injury to the patient. Can we move forward?
Yes, ma'am.
Yes, thank you. Next, we are going to discussing about the oral hygiene. We know 90% of the systemic diseases are mainly causing through poor oral hygiene, and oral hygiene is differ for the condition of the patient. In the first picture, the patient's upper limbs are okay, and he can do brushing by himself or oral hygiene by himself. In these type of patients, what we are doing is we are only assisting the patient. And in the second picture, if the patient is fully bedridden, we can move the patient tilt the head towards one side and we are providing oral hygiene. Next. And we should instruct the patients like the self-care education points are, we should teach them brush the teeth twice a day with soft toothbrush. If we are using hard toothbrush, it will cause injury to the gums and all. And we should instruct them toothpaste left in the mouth can cause dryness. So we should remove the complete toothpaste from their mouth after oral care. Then advise them to rinse the mouth with warm saline or soda bicarb solution. It will clean the mouth. And for the tongue, to be brushed with soft toothbrush, and advise them to take plenty of fluids, and we should instruct them denture should be removed at night. These are the self-care education points while we are providing oral hygiene. We are educating patients like this. And next. And this is a terminally ill patient's oral hygiene. We know if a terminally ill patient is admitted in the hospital, we are providing oral hygiene mainly by using normal saline. And most of our patients can't afford a normal saline at their home care settings. So before discharging, what we are teaching them is we should teach them how to prepare homemade salines. And for making homemade saline, we should instruct them to take 500 ml of water plus 1 teaspoon of common salt and boil and cool and keep covered until needed. Like that, we are preparing homemade salines. And instead of normal saline, we can use this homemade salines for oral hygiene. Then for how we are preparing soda bicarb solution is take 500 ml of boiled water and add 1/4 teaspoon of baking soda. And this is how we are making soda bicarb solution.
Hello, ma'am.
Yes.
Yeah, ma'am. I just want to ask you, no, the solution what we make at home, no, how long we can keep?
Because we can keep it for 1 week.
1 week. If not refrigerator.
No need to take it. No need to keep it in refrigerator.
Both the solution, ma'am.
Yeah.
can keep for the 1 week, right, ma'am? Then we have to make the
Yes, then we have to remake it again after 1 week.
Okay. Ma'am, betadine solution also we can make something like that homemade, ma'am. Something like is there or not, ma'am?
Detergent, you
No,
mean mouth?
betadine solution. Betadine. For the wound care, no, ma'am?
Wound care, this is basically on mouth care.
Yeah.
But going for like betadine and all other mouthwash, it's better we stick on with saline solution.
Only with the NS only we can do, right, ma'am?
Yes, this is regarding the mouth care. Wound care is something different. It depends upon the intensity of the wound. We have to provide medication, ointments, and all to the wound. So this is completely regarding the mouth care, how every day you can clean the mouth of the patient who's unconscious. Conscious people will be able to do it by themselves.
Ma'am, actually my question is that we are making a solution for the mouth care. If in wound and all, we can make the homemade betadine solution also, ma'am?
No. For our patient, if the patient needs betadine for wound dressing, we are providing that. For mouth care, we have a doubt whether betadine can be used.
Okay, thank you, ma'am.
Okay, thank you. And also instead of gauze, we can use clean cotton cloth instead of gauze pieces. Next.
Do you need to boil the cotton also, ma'am?
No, for oral care, no boiled cloths are needed. Only we are taking clean cotton clothes for oral care.
But okay. Thank you, ma'am.
Thank you. And next we are discussing about the catheter care. We know in palliative care, most of our patients are in continuous bladder drainage and on urinary catheters. And before discharging these patients to the home, we should teach them the importance of catheter change, and we should instruct them the need of catheter change in 3 to 4 weeks. And we know catheterization is a sterile procedure, and we should keep strict aseptic practices. Then we should teach them how to do perineal care. Perineal care means not only the perineal area, we are advising the patient to take care of from below the umbilicus to the mid-thigh. For perineal care, we are advising soap and water. While doing bathing, they can, along with that, they can take perineal care. Then advise them to take oral fluids, more oral fluids to prevent infections. For a catheterized patient, bowel care is very important. When a catheterized patient came to us, we should assess the bowel pattern of the patient, because if the patient is having chronic constipation, the hard stool will exert a pressure on the bladder, and it will increase the residual volume, and it will cause to infections. So bowel care is very important for a catheterized patient. So when a patient is discharged to home with continuous bladder drainage or urinary catheters, we should take care of their bowels also. So like Sister Reshma has said, as a volunteer who is non-medical, we can't do catheterization because it is a medical process. So as a volunteer, a non-medical person, we can only do catheter care, illustrating some of the points you have to remember while doing the catheter care.
Always wash hands with soap and water before and after.
So that is the points you have to remember while doing a catheter care. Any questions, or can we move on to the next? I guess it is a yes. Yes.
Ma'am, how do we recognize urine coloration, ma'am?
Urine coloration.
Yeah, means like the patient is suffering, and if infection is there, how do we recognize the color?
I think it's better we communicate with a medical professional instantly on the color, the difference in color, you know.
Mm-hmm.
Normally, light yellow will be the favorable urine color which we should be needed. If you find any pus or any difference in that, make sure you immediately call a medical professional and connect them with them. Maybe the caregiver doesn't know the difference or anything. So if you find any changes, you have to immediately call a medical professional. A medical intervention is really important in that case.
Okay, ma'am. Thank you.
Okay. Any other doubts? Okay, we are moving on to the next. If you have anything, you can ask in the chat. Next is about the ensuring compliance. In home-based care, we are providing the medicines on patient hand or family members with them, and they are handling with that medicines. But if the patient is admitted in a hospital, the nurses are giving medicines and they are closely monitoring the patients. And when we are issuing medicines in home-based care, we should give proper instruction regarding the medicines what we are issuing. If we are providing one medicine or pain medicine or any medicines for that patient, we should clearly mention the name of that medicine, dose, frequency, like that, and what is the indication for that medicine and what are the side effects, like that. We should clearly instruct the patient before issuing that medicine for that patient. And we should label the medicines given. If we are providing a morphine for that patient, on the medicine cover, we should write their own language. We are providing tab morphine 10 mg. Like that, we should write. Then check the number of medicines in each visit. For a patient with a patient is taking paracetamol 3 times a day. For that patient, 1 month he needs around 90 tablets. And on the home visit day, we provided 90 paracetamol for that patient. On the next visit, we should count the medications. If we are getting 50 paracetamols from that patient, that means he is not taking the medicines properly. Like that, in each visit, we should check the number of medicines. Then consider the financial status. Already the families are going through financial strains and we are prescribing more costly medicines. They can't able to brought that. So we should consider the financial status before prescribing medicine for that patient. Through these ways, we are ensuring the compliance. We should give proper instruction, label the medicines. In labeling, we should write the name of the medicines, the actual dose, and the dose for the patient. If the patient is taking paracetamol 750 mg means we should write that paracetamol 500 mg at 3 times means 6 a.m. 1 tablet, at 2 p.m. 1 tablet, and 10 p.m. 1 tablet. Like that, we should label on the medicine cover. And we should check the number of the medicines in each visit and consider the financial status before prescribing. Okay, what are the benefits? What are the benefits of home care? Is there any benefit?
The benefit can be that the person gets the care within his or own comfort zone without being conscious of the hospital or getting that anxious vibe of, that entire hospital setup. And also he can be with his family, which is very important to get the mental relaxation.
Yes, true. So we have some suggestions like it's a cost effective.
No transport cost can stay with the family members, which give him or her a mental satisfaction by staying with her family.
Yes. So there will not be any transportation cost, or also the patient can be with the family, so the emotional stress will be less too. don't have to incur the cost of travel. Same point. Patients feel more comfortable, less infections, less change of complications like infections. Yes, true. Next. And the main benefits are patient and family feel support. And in that picture, the patient is already getting continuous infusions, and the family members are very comfortable in their own settings. Like that, the main benefits of home-based care is patient and family feel support because they are at their own settings. And patient receive individual attention. It is very important in home-based care, each patient is getting individual attention and less social isolation. Because we are visiting the patient regularly. According to the health condition of the patient, we are deciding the follow-ups. If the patient is need repeated attention or repeated home visits, we can put it that patient on weekly visits. And we can, if the patient is needs more than that, we can arrange phone call follow-ups like that. According to the condition of the patient, we are arranging the home visits. We have monthly patients, 2 weeks patient, and weekly patients. According that, we are prioritizing the patient. Then patient remains part of the family because they are in their own homes. And full assessment of the patient and family is very easy to the healthcare professionals in home-based cares. And full assessment of the family and patient, then understanding of family dynamics is very easy in home-based care. Then it is easy to prepare patient and family for any anticipated difficulties and symptoms. These are the main benefits. These are some of the benefits. The main benefits, patient and family feel support and they are very comfortable with home-based care. Next. For an effective home-based care, something is needed. What is that? Is there anything needed for an effective home care? For an effective home care? A primary caregiver at home, community, yes. Like think more, like what all, how, who can do the entire thing together?
Yes, I think a team is needed, entire team by itself.
Yes, 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 correct, truly correct. Yes, a good teamwork is needed for an effective home-based care. Team means together everyone achieves more. And the team includes volunteers, social workers, nurses, doctors, physiotherapists, etc. But the only one thing is all need training. We need trained persons in effective home care team. And to cure sometimes, to relieve often, to comfort always. It is not how much we give, but how much love we put into giving. Thank you. So before moving on to the next question discussion round, we will quickly see a bereavement support visit, which will give you an idea about what are the conversation happening on a bereavement visit. I guess you have got a gist about the conversations which can be made during a bereavement support visit. Is there any questions regarding today's sessions? You can ask now, or any comments regarding you being part of any home-based care.
Do we get more training, especially for patient handling, or even if we have to go to their houses, you train us further so that we are more better equipped, or understand the problems better?
Yes, ma'am. We do have different types of training program with us. But the thing is that to have an in-house training would be good to know how a patient can be cared at their home. So the next level of training would be in-house training, which we prefer. so that you can understand, you can practice your conversations, communication, everything with the patient and all. So you can be part of any palliative care centers nearby. You can go to home care with them and understand everything, and then be part of their also hands-on training. So the rest of the things, these are the things we can deliver through a virtual platform.
Right, I understand.
Rest can be an in-house thing only.
Correct. Practice should be the given, otherwise it is so difficult, just hearing or reading, it won't be enough. Right?
Enough, correct. So we in Pallium India based in Trivandrum, we do have a 3-day workshop here in which volunteers come here. We will make them go to home visits and all, and make them aware about as a volunteer what they can do to the patients there.
Thank you.
Thank you.
Ma'am, in such situation, we need to give the counseling also, ma'am. Ma'am, can you provide some counseling courses also, ma'am?
Counseling as such courses at present through virtual platform, we don't have. We have it through in-house only. But there are many institutions which provide psychosocial or counseling kind of training. So I think you can directly talk to them. There are different programs by Indian Palliative Care Association Center. So we doesn't provide counseling training at present.
Okay, ma'am. Try to find out and please, like, we want to be a counselor part also, ma'am. Sometimes it's very important also. Like sometimes when you go to for the home visit, it's
Yes.
very far and like it's good not. But if you know something, at least 2-3 section needed.
Yes,
if you
yes.
can
Totally
provide for us,
understanding.
that will be very.
Yes, yes, totally understanding your need. Like I will have a conversation with our team members. If anybody came to know about these kind of training for counselors, we will let you know in the group.
Thank you, ma'am. Thank you. But if it's early as possible, that will be very much
Sure,
helpful to
sure.
us, ma'am.
We will try our best.
Thank you, ma'am.
Hi, good evening. I'd like to know more about the role about the palliative care executive group that was mentioned. What is their role exactly in the team? The palliative care executive.
So the palliative care executive, what we mentioned on the slide, is actually palliative care assistants who basically drive the vehicles to the patients. We don't need to call them drivers and all. So that is why we all are people who are supporting us. We term it as palliative care executives or assistants. And also like it would be good if we ourselves start using these terminologies than going for usual conventional methods and all.
Okay, thank you.
So we missed a question in between, how frequent we can make follow-ups from Anaka Paul. I think it has been cleared by the session, or do you still have a question on that?
No, it was answered later. Thank you.
So what we do is here, if a first time intervention would be a doctor-led home care. So if the doctor and nurse finds that a social worker need is there, then definitely we will arrange for another social worker visit to that patient. So it completely depends upon the need of the patient. So every team members who is going there will identify the need. So that is why Reshma always said it should be a trained person going and meeting. Whoever, even the palliative care assistants, the volunteers, everyone should be trained to understand what the patient needs at that time. We had a question on Arun by Arun, like do we have a detailed session on catheter insertion and all? So that is completely a medical thing. This is a training for volunteers, so we are not going into that aspect at all.
Okay, ma'am. Thank you.
Thank you, Arun. Any questions more?
Ma'am, can you explain, like you had talked about the morphine, ma'am? Can you give me a little bit highlight about the morphine, ma'am?
Like we can talk about morphine, but this group is something totally different. We are not
Okay, ma'am.
supposed to speak. So you can be part of our nurses or doctors programs in which they will be detailing about the clinical management, medical management and all. So this program is completely for what a volunteer should know to implement in palliative care.
Anyway, morphine, I don't think can be prescribed in all other parts of India. Kerala, you are allowed to. I don't think we here only have injectable morphine. We don't have morphine tablets, as far as I know. And they cannot be prescribed that easily either. I mean, there's quite a lot of regulatory things about morphine, isn't it?
Here we have tablets, syrups, and injections also available. Most of our patients are on tablet morphine, ma'am.
No, that is only in Kerala. But other than Kerala, I don't think morphine can be prescribed. It's under the regulatory. That's what I understand from whatever I've read.
In our Northeast, I mean, we have an Ignim hospital. They had prescribed some morphine tablets, but we need to go to hospital and get from there only.
Maharashtra also has facilities for prescription of morphine tablets. I think it's more to do with the provider, the prescriber, and the pharmacy from where you can get it. Those may be limited.
Absolutely. Yes. There is a lot of restriction.
There is a lot of restrictions also. There is a concept called recognized medical institution and practitioner. So there should be, they should have attended some kind of training to get that in their hand. So that is completely a different topic as such. Yes, Sunil.
Yeah. So I can see Padma ma'am. So Padma ma'am, hi, this is Sunanda. So all those who are from Maharashtra can contact me. Raju, you can just put my number. So I think this is not the platform as Raju was saying. So all your queries will be taken care of. So all those who are from Maharashtra can contact me. So we can talk about RMI that Raju is trying to explain. So I'm very happy that, you people are interested to know more and more about, not only limited to volunteers, what volunteers should know, but more about palliative care. It's good sign. So, but then we have limited time. So I request all of you to contact all those who are from Maharashtra. And Raju, you can put other regional coordinators number also. So for the details regarding RMI and other things, they can contact. Okay.
She has put it already. It's on the group.
Yeah, please note that and you can contact me. Aneka, are you from Maharashtra also?
Yeah, I'm based in Mumbai.
Yeah. So please contact me, and if you can just put your numbers also in the chat directly to me. So I'll contact you all. Okay, thank you very much.
Thank you, Sunanda. Any other questions or concerns? So we have shared our regional coordinators numbers in the chat option now. So pick up your region, call the regional coordinators. They will help you finding morphine or any other drugs and all. So as a volunteer, what you can do is that the doctor will be prescribing the routine, like if the morphine should be taken 4th hourly, 6th hourly and all. So as a volunteer, you can check whether patients are taking that in time, going with the clock and taking the prescription and all. If you're a medical professional, then that is something very different. So that is not in this perspective right now. So we have a question like to provide good palliative care, we need to have good rapport with the patient and their family. What are the approaches that we can follow or good rapport with the patients? So we have a detailed session on communication tomorrow, on which Dr. Radha will be letting you know how better you can communicate, what are the approaches you can take to the patients and caregivers and all. That will be covered by tomorrow. If we have any questions, you have any questions still pertaining, you can ask it for tomorrow's session. That will give you a continuation. Any other questions? I guess it is a no. If you still have questions, you can write to us at tipsecure.palliumindia.org, or you can give your questions in the WhatsApp group. Thank you, Sister Reshma, for that wonderful session. We can see you all tomorrow with another topic on communication taken by Dr. Radha. Thank you all for joining today. We'll see you tomorrow. Bye.